beer, beer, beer. You guys listen to the Chinese Bill Nye song? Dude, the Chinese Bill Nye song is so funny. It's like 比尔是科学家，科学定义。And they go like beer, 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 beer.
Beer, 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 beer. 比尔是科学家。
科学定律。
比尔是科学家。
惯性是物质的性质之一。
比尔是科学家。
倒数7秒，计时开始。
比尔是科学家。
Dude, that's the greatest thing in the world. Alright, 66-year-old woman is hospitalized for the worst headache of her life. CT of the scan without contrast shows diffuse subarachnoid hemorrhage with interventricular extension and hydrocephalus. Because of the patient's deteriorating mental status and agitation, her trachea is cannulated and a CBC is placed. Which of the following is the most effective strategy to decrease the patient's risk for developing catheter-related... Oh my god. Okay, so I feel like triple lumens are more risky to get infected than single lumens. You do not routine catheter replacements. Prophylactic systemic antibiotics is not, because this is very stupid. You would not do this. IJ placement versus subclavian site would increase risk for infection. Oh, okay, so it's chlorhexidine bath. Actually, honestly, this question wasn't that bad. If B, C, D, and E were like a little more like reasonable, like I'm not saying like they're right? Like obviously all of these are wrong, but if these were all reasonable answers and then chlorhexidine baths was one of them, and they asked me what of the following is the most effective strategy, I probably would not have gotten that right. Oh my god. Oh no. Dude, what are these questions? Oh my god, it's like, can I just get like a normal medical question? Did you check they were depressed first? I don't know. This is kind of like, can I just get like a normal medical question where we do medicine? The answer is either going to be he can totally drive or he should stop drive. Because like 100%, these are the only two answers, right? Like these are the only two answers that we can give. So it's he can drive or he cannot drive. And I feel like the question is going to try to give you a bunch of red flags and tell you that like he's super at risk for driving, but he's actually totally fine for driving. Are you confident in that? Because I'm confident in that. I'm just gonna say B, and I'm just gonna say F off. All right, good. Dude, these questions are so stupid because it's like only one answer can be correct, which means the other answer is wrong. So it's like, god damn it. Which of the it's another one. I'm just not gonna read the question again. Dude, what? It's a COPD patient. Which of the following do inhaled corticosteroids increase? Pneumonia. Ooh. Actually, wait. Which of the following do inhaled corticosteroids increase? Cardiovascular mortality or pneumonia incidence? B question mark? Like, I feel like it was E. Because I feel like I remember learning that. But I feel like cardiovascular mortality is also a legitimate thing. The rest of this does not matter. This entire thing does not matter. Like, this whole vignette is so pointless. Which of the following do inhaled corticosteroids? Oh, inhaled corticosteroids. Okay. Okay, yeah. Not systemic corticosteroids. Yeah, 9% of people said it increases mortality, which for steroids I would probably believe more, but inhaled corticosteroids, 100% it would be that. Is this a real question? Can this be a real question? Okay, guys, it's a real question. It's a real question. Okay, you always read the answers first. That is a good tip. Like, I'm reading the whole question because we're doing this on stream together, right? But usually, like, my actual test taking strategy is I read the final question. So it's like, which of the following, or what is the most, or like, what is the next step, blah, blah, blah. And then I read the answer choices. And then I work backwards and I read the question from the start. So if I was doing this like it was an actual question, I would be like, what's the most appropriate next step in the management of this patient? So I'd be like, oh, okay, it's a diagnosis question. So the answers are bronch with BAL, CT scan, NSAID and follow-up, oral antibiotic, clinical follow-up. So I'm thinking, okay, do they want me to think about pulm? Do they want me to think about cancer? Do they want me to think about primary care follow-up? Do they want me to think about like doing a VATS or something? This is how I read the actual paragraph now, because I'm trying to find clues that support, you know, oh, this deserves more of a pulm workup, this deserves more of an onc workup, etc. So total protein is less than serum, pH is lower than serum, and LDH is lower. This is just exudative. This is exudative. 42-year-old woman comes to the ED due to shortness of breath. Approximately 2 weeks ago, she has shortness of breath on exertion that became progressively worse. She reports mild chest pain with deep inspiration. She has had no weight loss, fever, cough, or sputum production. Medical history includes diet-controlled type 2 diabetes and locally advanced infiltrating ductal carcinoma of the left breast, which she already underwent neoadjuvant chemo and surgical resection and radiation 2 years ago. Okay, so she's already had cancer at one point. Patient is a lifetime non-smoker and has no significant secondhand tobacco exposure. She lives with her family and works as a teacher. Temperature is 99.7, blood pressure is 122/78, pulse is 92, respirations are 20, oxygen sats are 92% on ambient air. Physical examination shows moist mucous membranes with no JVD or lymphadenopathy. Heart rate is regular, with no murmurs or gallops. Auscultation reveals decreased breath sounds over the right lower lung with dullness to percussion, which you can see on the x-ray. Remainder of the exam is normal. Upright chest x-ray reveals the following. But you can basically see that she has no costophrenic angle on her right-hand side. So over here, you can see this little dip over by the stomach where you can see that you are able to visualize this space where the lung is having enough volume to expand and have air over here. On this side, you have a big pleural effusion over here that's completely whiting that out. So obviously she has an exudative pleural effusion, and I think the question is asking you, is this going to be like a palm problem? Is this a parapneumonic effusion? Is this going to be a metastasis? So the cytology says negative for malignant cells, but I do not think that has much value here because the fact that she already had cancer with radiation, resection and radiation 2 years ago, like I'm calling this a malignant effusion until otherwise. So oral antibiotic clinical follow-up, like not appropriate. She has an effusion. It's not parapneumonic. Non-steroidal anti-inflammatory agent and clinical follow-up, like shortness of, like what is that going to do? What? Bronchoscopy with BAL, I mean, you're not going to get anything about the effusion from the lavage, right? So it's like, I'm not going to say that these are good answers, but does she need a pleural biopsy? Probably not, because we already have a potential source. So yeah, okay. The 27% of people already did this here. Thoracoscopic pleural biopsy can be useful in diagnosing suspected malignant pleural effusion or pleural effusion of unknown etiology. However, CT scan should be performed first to guide the location of biopsy. Okay. 33-year-old man comes to the office due to persistent anal pain. 2 months ago, the patient experienced severe anal pain associated with bowel movements. Evaluation revealed an anal fissure and external hemorrhoids for which he was treated with stool softeners and topical nitroglycerin. So he had stool softeners, topical nitroglycerin. His symptoms have persisted despite adherence to medical therapy and high fiber diet. So he's still having anal fissures. He's still having anal pain. And every time he has a bowel movement, so anytime he's pooping, like the stool is hard and it's passing over the fissures and probably the hemorrhoids too, and it's granting him a lot of pain. His symptoms have persisted despite adherence with medical therapy and high fiber diet. He reports no history of anal trauma or anal intercourse. Vital signs are within normal limits. Rectal exam is painful, reveals a posterior midline anal fissure, large skin tag, and external hemorrhoids with no thrombosis. The remainder of the physical exam shows no abnormalities. Blood counts and serum chemistry are fine. Which of the following is the most appropriate next step in the management of this patient's disorder? So he reports no history of anal trauma, no anal intercourse. So, syphilis, HPV leading to malignancy is less likely. Actually, I think this is Crohn's, right? He's 33, right? So he's a young guy. He's the right age. And the biggest thing was with Crohn's, as opposed to the other inflammatory bowel disease, ulcerative colitis. Ulcerative colitis only affects the mucosal layer of the intestines, whereas Crohn's affects transmurally, which means it affects the entire wall. And these big knife-like fissure lesions, they happen from the mucosa all the way to the basement membrane. So when you get anal tears and anal fissures, these are actually just Crohn's lesions that are extending transmurally across the whole thing. So I'm gonna say we have to rule out Crohn's because, I have nothing to suspect that it might be HPV or it might be, internal hemorrhoids or anything. So patients with non-healing atypical anal fissures, colonoscopy, and small bowel imaging to rule out Crohn's disease. So he's been on all the correct therapy, but he keeps getting recurrent external hemorrhoids and anal fissures. You probably want to make sure he doesn't have a GI pathology there too. 22-year-old woman comes to the urgent care clinic with a painful, gritty sensation in her right eye, swelling, and photophobia for the past 2 days. She's been studying for college exams and initially attributed her symptoms to fatigue. The patient wears contact lenses for myopia. You think it'd be like corneal abrasion or whatever. You can't contact lenses, you're worried about Pseudomonas. So you have to, yeah. I don't have a good reason for that. It's just anytime someone comes in with contact lenses, you have to treat it like it's Pseudomonas, and you have to make sure that you moxifloxy that, because if you don't moxifloxy it, erythromycin's not going to take care of it. It's not moxifloxy, it's gadafloxacin. What the is gadafloxacin? It's a 4th generation fluoroquinolone used for eye infections. Oh, it literally, oh, it's okay. It's literally just like a eye fluoroquinolone, yeah. But yeah, broad spectrum topical antibiotics with Pseudomonas coverage. So basically it was just like contact lens, acute bacterial keratitis, contact lens, fluoroquinolone. 44-year-old man with HIV infection is evaluated for persistent fevers, progressive generalized fatigue, poor appetite, and marked weight loss over the last 2 months. He has no chest pain or shortness of breath. He's been non-compliant with antiretroviral therapy, and his last CD4 count 6 months ago was 90. Okay, so not terrible. Not great, but not terrible. His temperature is 38.3, 101, okay. BP is 91/53, pulse is 105, and respirations are 21. Exam is pale conjunctiva, dry mucous membranes. Okay, so this guy is not doing too good. Hemoglobin 7.8, platelets are 70. He's got like no leukocytes. CT scan is, oh god, lucencies in the skeleton and bulky mediastinal and abdominal lymphadenopathy. Bone marrow biopsy in this patient would most likely show which of the following. Oh man, okay, so I mean, he has acute HIV. He's non-compliant with antiretroviral therapy, so I mean, he's like super immunocompromised. This is lucencies in the skeleton is probably a trap answer for multiple myeloma. Just off of nothing else, bulky mediastinal and abdominal lymphadenopathy is making me think non-Hodgkin's. Kaposi's, I mean, I don't see any sarcoma signs. Fungal infection, I mean, I don't know. Like, I would say all of it is acute HIV until it got to the bulky mediastinal and abdominal lymphadenopathy. It's screaming at me non-Hodgkin's, but like, I don't have a better answer. Lucencies in the skeleton, I mean, the adenopathy is giving lymphoma. Like, is it wrong for a lymphadenopathy to give a lymphoma? Like, it's giving. Damn, I actually don't know. I want to go with my gut. It might be wrong though. Oh, okay. Dude, what? This was rough. This was rough. Patient's poorly controlled HIV status, marked body cavity lymphadenopathy, and bone lucency. The most likely underlying cause is non-Hodgkin's. Around 4% of HIV patients have lymphoma at the time of diagnosis, with the same percentage developing lymphoma during their disease course. Factors that contribute to the incidence include direct effects of HIV, immunosuppressive state, co-infection with other oncogenic viruses like Epstein-Barr, and environmental oncogenic stimuli. Heart prevents severe immunosuppression, which in turn helps decrease the incidence of non-Hodgkin's. Patients with non-Hodgkin's tend to present with B symptoms. Yeah, so that's where I was getting it, right? So it's like the bulky lymphadenopathy with the B symptoms. But then it was like complicated with the HIV. So I was like, I don't know. 80-year-old woman comes to the physician accompanied by her daughter, who is concerned because her mother no longer participates in group activities. Patient has lived in... Oh, come on. No! Why? Home geriatric assessment. 100%. I don't care. Patient has lived in an apartment with an Okay, well, she lives in an assisted living facility, so I don't think it's home geriatric assessment. She no longer attends communal movie nights or bingo games, eats all of her meals in her apartment, oh my god. She feels well and has not been depressed or fatigued. She says she sometimes forgets stuff, but is still able to function independently. Hello, she just gave like 4 things she doesn't do anymore. She's not fallen in the past year. Patient has osteoporosis, hypertension, osteoarthritis, blah, 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 medical problems, blah, 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 proper noun, place name, blah, blah, blah. She's alert, attentive, pleasant, well-dressed, well-groomed. Chest abdominal exam are unremarkable. There's no muscle weakness. DTRs are normal, gait is steady. 27 out of 30 on the MMS. Oh, wait, geriatric depression scale screening test is negative. She's not depressed or she doesn't have cognitive issues. Oh, you know what I think it is? I think it's this. All right, let me just check. So hematocrit's fine, MCV's fine, platelets are fine, leukocytes fine. This is fine. Kind of elevated. Fine. So thyroid replacement therapy is not going to do anything. That's a trap answer. I don't think neuropsychologic testing is needed because her MMSE is still good. I think it's hearing evaluation. I think it's actually hearing evaluation. I think it's hearing evaluation because of the question stem. She doesn't attend movie nights. She doesn't attend bingo games. She doesn't watch her favorite television shows. And she doesn't call her family or friends. Dude, it's hearing eval. Oh my god! Look, you know, if this wasn't here, the answer 100% would have been mood. 23-year-old woman with known type 1 diabetes and systemic lupus is admitted with low-grade fever, nausea, and headache. Oh, guys, it's lupus! It's lupus! It's lupus! So she has type 1 diabetes, lupus, and she's got fever, nausea, and headache. She takes prednisone, hydroxychloroquine. Nice. Nice. Hydroxychloroquine is first line in lupus. More primary care providers should feel comfortable prescribing Plaquenil and then referring to rheumatology. Don't just snow out the patient with anti-inflammatories and then expect the rheumatologist to get any useful data out of that. Hydroxychloroquine is the first line medicine, but you also need to get your retinas checked because hydroxychloroquine is toxic to the eyes. All right, so prednisone, hydroxychloroquine, and multiple daily injections of insulin. She also uses decongestions for seasonal allergies and omeprazole for acid reflux. Initial lab results are as follows. So platelets high but fine, leukocytes fine, bicarb fine. So she's acidotic. So lumbar puncture shows a protein of 23 and no white blood cells. Wait, what? I thought we were doing DKA here. Okay, so urinalysis shows no evidence of infection. Patient is treated with IV fluids and insulin. So she does have DKA, but they did an LP. I don't know why they got an LP. On the second day of hospitalization, she complains of worsening headache and blurry vision. On physical exam, she's mildly lethargic. There's right-sided periorbital swelling and tenderness over the maxilla. So she has like a sinus infection. There's no lymph node enlargement and the neck is supple. Chest exam is unremarkable. Why did they do an LP? Patient would most likely require which of the following? Anti-pseudomonal antibiotics, MR angiography of the neck, repeat lung puncture, repeat lumbar puncture, surgical treatment, transesophageal echo. What the f? Okay, diabetes. All right, so anti-pseudomonal antibiotics is probably on there. So right-sided periorbital swelling and tenderness over the maxilla is this big ball of mucor. Ooh, mucormycosis. Is this the one that's like black, right? I remember the sketchy for this. It's like an oil change station because it's like mucor is like a black fungus or something. 52-year-old woman comes to the physician for a routine follow-up. She has no complaints and thinks of herself as pretty healthy. Oh, okay. That's always a good sign when the patient's like pretty healthy. She takes lisinopril and hydrochlorothiazide for hypertension and lansoprazole for GERD. She was treated with isoniazid for latent TB 7 years ago. Okay, so this is definitely something that you always want to see. So she is on 2 blood pressure drugs and a reflux medicine. Her mother died of uterine cancer at 62. She doesn't smoke. She jogs 3 miles a 3 miles a day at 52? Wait, that's pretty good. What? All right, she takes 2,000 units of vitamin D3 a day orally as a dietary supplement. Blood pressure is 139/82 and pulse is 74. BMI is 28. There's no neck masses or lymph node enlargement. Breast exams are unremarkable. Lungs are clear to auscultation. Spleen is not palpable. There's no skin rashes. So she doesn't even have complaints. She's here for a routine follow-up. What are we looking at? So sodium fine, potassium is fine, chloride's fine, creatinine's fine, calcium's high, glucose, yeah, low, but it's fine, albumin's fine. Repeat calcium is 12/1, okay. Hydrochlorothiazide is discontinued. Oh, Which of the following is the most likely diagnosis? Okay, so do we have a vitamin D level? We don't have a 25-OH level either. Okay, are we concerned about active granulomatous disease? If we had active granulomatous disease, we would have increased peripheral conversion of 25 to 125, and you would have an increased absorption of calcium. She was treated for 7 years ago. She has no complaints. She's jogging 3 miles a day. I don't know if she has like active TB. Occult malignancy. I mean, she could have an occult malignancy. She could be, busting through a bunch of cells, but if you were worried about cell breakdown and things, you would have potassium also high as well. Osteoporosis, she's 52. She's 52, she has no complaints. She takes D3 orally as a supplement. Parathyroid adenoma. I mean, it's not impossible that she couldn't have a parathyroid adenoma. Is it vitamin D toxicity or is it osteoporosis? Is this an absorption from too much vitamin D, or is this a bone resorption problem from the body telling the bones to give up their calcium? All right, vitamin D. Parathyroid adenoma! No! All right, well, this was clearly very rough because it was like a 48%er question too. Like, what the 37% said parathyroid adenoma. So, I mean, I feel like vitamin D toxicity was a very valid answer. All right, let's go through this because I had a lot of trouble with this. Primary hyperparathyroidism is the most common cause of hypercalcemia. Really? Not like, I don't know, dehydration? All right, whatever. Patients with primary hyperparathyroidism are usually asymptomatic and present with incidental hypercalcemia on routine laboratory testing. However, the serum calcium in primary hyperparathyroidism is only mildly elevated. So normally your parathyroids are these glands that sit behind your thyroid, and they secrete something called parathyroid hormone. And the way that this axis works is that it's there to balance out, the levels of the phosphorus and calcium in your blood. The way I remember it from med school is like PTH is phosphorus trashing hormone. So it encourages the kidneys to excrete phosphorus, and it does that by pulling more calcium. And with PTH, you can leach calcium from the bones because with high PTH, like from a tumor or something, independently producing PTH, it'll be like, I need calcium, I need calcium, I need calcium, and it'll start grabbing that from your bones. This patient is asymptomatic and was incidentally found to have mild hypercalcemia. The most likely etiology of her hypercalcemia is primary hyperparathyroidism, which is the most often caused by a parathyroid adenoma. So, I mean, if primary hyperthyroidism is the most common cause of hypercalcemia, and she has hypercalcemia, then I guess it wants you to say that it's parathyroid.